Morning, everyone. My name is Francesca. I've been working with in the lab of Mariam, of Dr. Mariam Aboian with Ludovico for the last 2 months. And today I'm going to talk about the new frontiers in central nervous system tumor classification and diagnosis, and especially about the role of neuroimaging in the future of the classification and the diagnosis. We're going to start talking about the WHO classification of the tumors of the central nervous system. Basically, we had 5 editions, and the last one was published last year. Starting from 2007 to 2021, there have been many improvements in those classification, especially from 2016 to 2021 editions. Basically, on the 2016 editions, the CNS tumors were classified only based on the histopathological features of the brain tumors, and in 2021, it was updated by inserting either both the histopathological features of the tumor and the molecular findings of the tumor. What is missing? What is missing is basically the neuroimaging part, which could provide so much better understanding, classification, and diagnosis of CNS tumor. My work was on 2 projects in the last 2 months. One was building a case report, analyzing a rare brain tumor case, searching for unique imaging features that could help us providing a better diagnosis of this CNS tumor in particular, and helping differential diagnosis with different brain tumors. And I worked on the developing of an image-based search tool, which would help to perform an image-based search in the hospital database, allowing us to improve the diagnosis of brain tumors. I'm going to start talking about my case report, which is about lymphomatoid granulomatosis. Lymphomatoid granulomatosis is a rare proliferative disease, EBV-driven, which means that it follows a previous EBV infection. The pathological damage of this disease is caused by the rapid expansion and proliferation of lymphocyte clones, which are most oftenly of a B cell phenotype, but can also be of a T cell phenotype, especially in HIV positive patients. The LOIG lymphomatoid granulomatosis is most commonly a systemic disease which originates in the lung and subsequently involves the skin and the central nervous system. What can happen is that there have been documented rare instances of primary CNS lymphomatoid granulomatosis, so a primary brain lymphomatoid granulomatosis. Why is it important to diagnose this disease? Because the primary differential diagnoses are with CNS lymphoma and vasculitis, but the treatment is really different. Therefore, it's really important to be able to diagnose this type of tumor. The problem is that the symptoms at presentation can vary a lot and are definitely not specific, and they can happen also in different brain diseases or brain tumors. So the symptoms could be such as headaches, vomiting, dizziness, dysarthria, and go on. It's really important to grade lymphomatoid granulomatosis, and the grading is based on the predominant lymphocyte phenotype, the amount of necrosis, and the amount of EBV positive cells. Therefore, a biopsy is always needed to diagnose this disease. Clearly, the higher the number of EBV positive cells, necrosis, and proliferation, the higher the grade of lymphomatoid granulomatosis will be. And this is really important because it will guide us on the treatment. Treatment that is yet to be standardized, unfortunately, because the disease is pretty rare, but common treatment options include chemotherapy, steroids, immunotherapy, radiotherapy, and surgical resection. Surgical resection is always to be considered as the last option because the patient should undergo a craniotomy, which is a really malignant procedure. Basically, our cohort of LOIG patients consisted of more than 90 patients. 5 of them have had central nervous system involvement, and we built a case report on one of them. Our patient is a 48-year-old man, HIV and HPV positive, that was transferred to a hospital from an outside facility because he had refractory and recurrent seizures. He was treated for the seizures, but those continued, therefore, and there was a progressive decline in mental status. He presented to our hospital with a set of scans from an outside facility. This is a T1, and we can see here highlighted by the white arrow that there is a round, well-bordered, hypointensity T2 lesion that shows gadolinium enhancing, that shows contrast enhancing in post-gadolinium T1. The same lesion can be seen on axial scans and is showing hypointensity on T1, hyperintensity on T2, reduced diffusion on DWI, and has a low value on ABC, as Ludovico kindly explained before. We can see that there is no shift in the midline of the brain, which means that the midline of the brain, as we can see perfectly in the actual scan, is perfectly right and is not shifted by the tumor. So what happened? 1 month after, our patient got another set of MRI at our hospital. And as we can see here, the first lesion is highlighted by the white arrow, but the white arrowhead highlights a new, bigger, rounded lesion that develops in the time span of a month. This lesion shows a fair amount of perilesional edema and shows, especially in T1 and post-gadolinium T1, shows cavitation. Both the perilesional edema and the cavitations are a sign of a really aggressive disease. As we can see from this actual FLAIR scan, we can see a huge amount of peritumoral edema, and we can also see here a left hollow hemispheric subdural hematoma, which was probably the cause of the seizures. And we can see from this T1 axial scan that there is a new midline shift, which means that the new lesion is actually really aggressive because it's moving the parenchyma of the brain. On these 3 scans on T2, we can see how the lesion involves both the white matter, both the white matter and the gray matter above. The patient underwent a craniotomy to drain the hematoma, and he got a biopsy. And in this biopsy, we can see this is a hematoxylin and mucin stain. We can see the angiocentric nature of the proliferation of the lymphocytes amid a background of inflammatory cells, here highlighted as a plasma cell, for instance. We then performed an in situ hybridization to highlight the EB positive cells, and we found that the number of those was really few. Therefore, the patient was diagnosed with grade 1 lymphomatoid granulomatosis. And as you can see, from this stain here, we can see that the CD20 positive lymphocytes are way much more than the CD3 positive lymphocytes, allowing us to say that the CD20 is the marker for B cells. Therefore, the predominant lymphocyte in this patient would be a B cell phenotype. What's the EBV role in this disease? Basically, after the first encounter and the primary infection, the EBV, the Epstein-Barr virus, remains latent inside of B lymphocytes and is kept under control by T cells, especially CD4+ and CD8+. Clearly, immunocompromised status can lead to EBV positive cells proliferation and possible malignant transformation. Therefore, this is the main problem of HIV patients, because HIV targets CD4+ T cells, who are the one who keep these diseases under control. Therefore, HIV positive patients have a higher chance to develop lymphoproliferative diseases, and the disease tends to be way much more aggressive. As we see in our patient, this is the first status scan with only 1 lesion, and this is the second set of scan that was taken exactly 1 month apart with 2 different lesions, and the new lesion that develops in less than a month is bigger and is cavitated. Therefore, the disease is really aggressive. Our patient was set to therapy with heart therapy and steroids. He was then discharged, and unfortunately, he was lost at follow-up. Second part of my project, or the second project I took part in these 2 months, I worked to help my colleagues in the lab to develop an image-based search workflow. So basically, what happens when a radiologist is not sure about a diagnosis? He can consult Radiopedia, he can talk with colleagues, consult literature, textbooks, internet. But is there another way? Probably yes. What if we use the hospital data set? Basically, in our hospital, we have the PACS, which is the Picture Archiving and Communication System that in Yale New Haven Health is visage imaging. And it contains thousands and thousands of cancer images that are associated with valuable pathological, histopathological, and clinical data. When reading a new patient with a brain tumor, finding similar images on PACS can really help us generate a differential diagnosis and lead our diagnosis in the best way possible. Therefore, the lab proposes an image-based search workflow that uses auto-segmentation and automatic feature extraction to use as a diagnostic aid. More than that, the lab developed a tool that helps in performing the automatical segmentation of the tumor and to extract features that are used within the PACS. How does it work? So we have our data, our MRI scan in post-gadolinium T1 and on FLAIR that are our unclear case, let's say so. We pre-process that. So basically we segment the tumor in its entire entity, then we segment the tumor core, the eventual necrosis, the eventual cysts, and the peritumoral edema on FLAIR. Then we use the algorithm and machine learning to extract quantitative features such as shape, texture, and intensity. Then the algorithm will perform a dimensionality reduction from more than 1,000 quantitative features to around 10 quantitative features, creating, as we can see here, tumor clusters that divide all the tumors that we have inside the PACS in different entities. Therefore, it will allow us, so this is going to be the process, the real process on the algorithm, it will allow us between these tumor clusters to retrieve the closest or most similar cases to the one we are not sure about. Such as, this is a perfect example for that. So we have our query case, our unknown or unclear case. We put that after segmentation in the algorithm, and it is going to give us like 3 retrieval models in order to provide us a better differential diagnosis. My contribution was on meningiomas because inside of this algorithm there will be 4 entities of the brain tumors. That will be glioblastomas and astrocytomas type 4. Then there will be low-grade gliomas, meaning astrocytomas type 2 and type 3, and oligodendrogliomas type 2 and type 3, pilocytic astrocytomas, and meningiomas. My work was on meningiomas, so I helped retrieving all the cases from 2020 and 2021 tumor boards. I performed a manual segmentation, which is this thing here. And I helped in the creation of 2 different cohorts, one of typical meningiomas, which are the one that you see above, that show really typical features, and atypical meningiomas, which are really different, so much more aggressive, with peritumor edema, necrosis, cysts, whatsoever. What are the outcomes of this project? It will definitely provide a better differential diagnosis assistance and will help in building databases with the annotational imaging. It will be really important to provide amazing radiology education, and eventually, in the future, it could provide a better image-based tumor classification in a new edition of the WHO tumor classification. I would like to thank all the Imaging Quant Lab, the Basement Bunch, and the Wright Lab, the ONAOSI, and all the friends that I made here for making this experience really amazing. Thank you so much.
It was great. I feel a little sick after.
That's exactly what I wanted.
Yeah, that's okay. Once more, I mean, the instrumentation plays a role. It's
Absolutely.
Really interesting.
Absolutely. It could definitely change the way we see brain tumors.
Very good. Questions?
I have a question about, so you were segmenting these tumors.
Yes, the meningiomas.
Was there a tool that you were using?
I was
segment?
using Visage. Using Visage, and especially the research Visage. So basically, I was querying the cases on Epic, and then sending them to Visage. And from the clinical Visage, I was sending them to the research labs. And there, I was performing the segmentation, both of the tumor core and of the perigeal edema.
Okay, and I was wondering, was the segmentation you had to trace out the edge of every slice yourself? Yes. Or does it automatically kind of help you in between slides? Because sometimes these are big, right?
Oh yes, they can be. Well, actually, when I was segmenting the meningiomas, we still did not have completed the automatic tool to segment. But on Visage, you basically start from the very middle of the tumor and segment like the biggest portion you have, and then go to the very end on one side and to the very end of on the other side, segment those 2, and then in between, the tool will kind of automatically recognize the tumor. Of course, you have to go through this because it will not be like super precise and everything, but it's helpful. I mean, it's helpful.
Okay, that helps.
Yes.
As someone
but
who's
it's time consuming. You need to have a really good playlist or podcast. Absolutely.
One more? Yes.
Yeah, I guess, so I was interested, you were looking within the hospital data sets, but is there a push for rare things to look nationally, or is this just too complicated?
We are still working on that. This is just the very beginning, and it's going to be presented at ASFNR next week on Hawaii. So this is the very beginning. We started from here, and then we will see where it leads us, but it would be really interesting to have it nationwide or worldwide.
Yeah.
That would be like the major goal. Definitely.
Okay. Once more, thank you very, very much. Now we move to Margherita Montavoci of the